at diagnosis. And as you can see, over time, there's been a trend on stage migration due to PSA use. And on the bars located on the right side, you can see the red color and the orange color highlighting that the incidence of high-risk tumors go from 13 up to 23%. And what's the difference in the definition? So the high-risk prostate cancer is defined by patients who have a PSA above 20, a clinical stage above T2C, or sometimes defined as T3A. So the first point of a distinction and differentiation in the definition is about the clinical stage. And this is important because when you're comparing studies, when you're comparing the outcomes, this might play some role in the different outcomes that we observe. In patients who have a Gleason score, a total sum score of 8, 9, or 10, or the new Gleason grading group of a 4 and 5. More recently, there has been a subclassification into very high risk group within the high risk tumors, and that's defined by having a clinical T3B or T4, a primary Gleason pattern of 5, or a total Gleason score of 8 to 10, and 4 or more cores. So what's the rationale for local treatment in the high-risk prostate cancer? So historically, the doctors tend to think that this disease was actually advanced and that these patients had micrometastatic disease, so it was not uncommon for them to just consider these patients too advanced for local treatment and they start hormonal therapy. More recently, that when we start seeing treatment both from radiation standpoint or surgical standpoint addressing the primary tumor, and this is one of the old CAPRA database papers showing how surgery was underutilized compared to intermediate and at low risk in this disease. The pivot data you guys are very familiar with shows the comparison between radical prostatectomy versus observation in patients with prostate cancer. So this includes all stages, not only the high-risk ones, but you can see this forest plot on the overall survival, and I'm going to zoom this table so we can focus on the area of interest here. You can see that the PSA, the risk groups, and also the Gleason score, they're all trend towards a benefit on intervention versus observation. Same thing can be observed in the cancer-specific survival. Zooming this table, similarly, we can observe the PSA trends, the high-risk group, and also elevated Gleason being significant or trending towards a benefit to intervention versus observation. This is data from Dr. Cooperberg and showing the temporal trend that has happened after the year 2000 or 2005. And you can see in these curves right here how the utilization of surgery approach in patients who have a CAPRA score of a 6 to 10, meaning a high-risk group by their definition, happen, and this is probably due to increased awareness of potential curative role, a more multidisciplinary approach that become more disseminated, and emerging data from retrospective, small single centers, academic centers publishing their own experiences in treating localized disease. And I would also attribute that to the dissemination of robotic surgery. So until then, prostate surgery was a very complex procedure. It was a procedure that was only restricted to centers of excellence with very few surgeons doing this routinely. With the robotic surgery explosion in the US, what happened is a lot of surgeons now are performing this operation. So it's a popularization of a radical prostatectomy is probably accounting for this as well. So what are the options? If you look at all the guidelines, the European guidelines, American guidelines, the ASCO, NCCN, this is very consistent. So the options for managing patients in this setting includes radiation. So the modalities are external beam radiation associated with a long-term androgen deprivation therapy, and long-term means 2 to 3 years. It could be external beam associated with a brachytherapy plus minus the long-term ADT, also for 2 or 3 years. These patients can be managed with surgery and a pelvic lymph node dissection, and they can also be managed when The other two options are not good options, or the patients are not good candidates for those modalities. They can be put on hormone ablation directly. There's a lack of randomized controlled trials comparing those modalities head-to-head, so we can't tell which one is the best approach. So when you try to compare one versus the other, this is probably not the best way to go. Instead, we try to add all these modalities together, and the word here is multidisciplinary modality approach. So when you combine surgery with radiation and androgen deprivation therapy to achieve best results. Here are some points that might justify why we can use surgery in this setting. So first of all, after surgery, you can identify the most important and strong predictor factors for cancer-specific survival. So one of them is the final Gleason score on a specimen. Secondarily, we're going to have the final pathological T stage. We can have a final staging from the lymph node invasion, extracapsular extension, seminal-vesical invasion. So having all those factors in our hands, we have more data and more information to determine the risks that these patients have, and then the accurate staging will lead to best selection for adjuvant therapies. Just like we've seen, for example, on the Messing trial when adjuvant therapy was given for patients with positive lymph nodes. Surgery has provided good oncological outcomes. So this is data from Brett Carver Memorial, and these figures here, they are present across all the other studies. I'm going to highlight a few of them at the end, but the cancer-specific survival is around 85% at 10 years, and the 75% at 15 years, and this being consistent across the board on all different series. We know about the downstaging phenomenon. So 35 to 45% of these cases, they are downstage from T3 disease to T2. So that's another good thing, that these patients can be spared toxicity of more toxic treatments. There's also downgrading effect. So up to 31% of these cases, they have a reduction in the Gleason initially seen on the biopsy and thought to be 8, 9, or 10 to Gleason 6 or 7 in final pathology. So we believe that all these things will allow for a possible avoidance of ADT, either alone or in combination with radiation therapy, and its side effects. We've learned recently as well, and you're probably going to hear about this today, that androgen deprivation therapy comes with a catheter of the side effects, so depression, loss of libido, incapacitating hot flashes, diabetes, metabolic syndrome, osteoporosis with potential for fractures. So we need to select very well who are the patients who need to receive this therapy. And also there's the local control provided by surgery, and most of the data that I'm going to show to you cites 13% of a local recurrence in patients with high-risk tumors treated with surgery. And this is also a good advantage because you prevent further complications in terms of urinary symptoms, bladder outlet obstruction, urethral obstruction, hydronephrosis, and also hematuria pain. I'm not sure how many urologists you have in the audience, but not to be too technical, one important point that I want to mention is the extension of node dissection when you do the surgery. So if you see on the left, if you notice left side on this diagram, this is just a limited pelvic lymph node dissection when the surgeons typically just sample the nodes between the iliac vein and the obturator nerve. Especially in patients with high-risk disease, we need to do a more thorough, more full lymph node dissection in the pelvis, including all these packages, and the template needs to be a lot more extensive. This is data that we published in Memorial when I look at Dr. Scardino's data, and we observed that mapping these nodes, more than 50% of the nodes would be missed if you do only a sampling node dissection, and you have impressive numbers of nodes located in the obturator and hypogastric areas that are not even approached in the limited dissection. So going now a little bit on the outcomes of patients who receive radical prostatectomy, there's several papers I'm gonna list it here. I'm gonna go a little quickly now because they basically give the same message. This is a retrospective study from Baylor and the Memorial Sloan Kettering, including almost 6,000 patients, and they tested different definitions of high-grade disease. So you can see in this table there are 8 different definitions, and then they're just comparing outcomes with a median of a 5.5 years follow-up. And as you can see in this column, from the metastasis-free survival, the survival goes around 85% or more at 5 years, and around 72% or higher, just like I mentioned before. When you look into the prostate cancer specific mortality, you can notice that the number of events, either at 5 or 10 years, are very, very small, meaning the survival with this approach is actually pretty good. And it's important to say that this is not surgery alone. This is all retrospective studies, observational studies, so there's no way to control and isolate that. So these patients actually received surgery, and a good fraction of them were either salvaged or received adjuvant radiation or hormones, or a combination of both. So this is actually looking into the effect of surgery as the first-line therapy within this multidisciplinary approach, and not surgery alone. So these are just a Kaplan-Meier curves showing the same effects, but in a graphic format. Each one of those graphics correspond to a different definition, and as you can see on the blue curve, the survival is actually not as bad for such a high risk and aggressive disease. This is another retrospective study, multi-institutional, including more than 12,000 patients, 15 years of follow-up, looking at the cancer-specific survival for patients receiving radical prostatectomy with or without adjuvant therapy. And again, looking at the surgery, this is a competitive risk analysis. Blue is mortality for other causes, and the gold is mortality for cancer. You can see the curve is very low. Cancer-specific mortality is about 12%, and overall mortality 38% in this group. Only 4% had predicted cancer-specific mortality greater than 5%. So it's surprisingly good results for such aggressive disease. Another study, 580 patients, retrospective, single center this time, and this was looking at patients with Gleason 8 to 10, undergoing surgery. They're looking different era, before PSA and after PSA. There's no difference with that regard, but looking at their table, if you focus on these curves representing the oncological survival endpoints, you can see the survival is actually pretty good. It's above the 85% range that we mentioned. Similarly, not a retrospective, single center. This is a smaller study, 230 patients only, but these authors were focusing on the high PSA, and this is a clinical dilemma we see very often. Sometimes you see patients with PSAs of 50, 60, 80, and when you do the metastatic workup, they're negative. You cannot find any metastasis. So what do? Intuitively, we think they have metastatic disease, micrometastatic disease, but we cannot prove it. So these authors treated them with surgery first, and as you can see, survival didn't change, even stratifying for those with PSA below 99 or above 99. After surgery, they also stratified for the adjuvant therapy these patients receive, either hormones, radiation, both, or none. And you can see as well that these curves, they don't separate, they don't stratify, meaning the initial approach might be doing something good for these patients. Another series of 5,600 patients, 15 years of follow-up, this time focusing patients with a T3 disease, receiving surgery first. So again, if you look on the green line on top, that is for patients with T2 and 0 disease, and the red curve is T3 and 0 disease. You see there's no difference there. On this side of the curve, when we're talking about death from prostate cancer, same definitions. This lighter green curve here represents patients with NET but positive lymph nodes. So you see that's also patients with positive lymph nodes can benefit from local treatment. Treatment of metastatic disease is not my topic this morning, but just to throw out there, even patients with localized node disease can respond and have better outcomes with a localized therapy. Different series, and you see again local recurrence-free survival, prostate cancer free survival, systemic progression, overall survival. All the numbers are good. Even with a longer follow-up, they followed this man for 20 years with a median of 14.3 years. I think I have one more. This is a multi-institutional from Europe, also retrospective, 2,000 patients, 20 years follow-up of a median of 17 months across all the patients. And this was the only study that were looking at radical prostatectomy alone. So these patients did not have adjuvant plus minus therapy afterwards, and still their 10-year cancer-specific mortality was 14.8%. So it's not too bad. Interestingly, they observed that the patients who had biochemical recurrence sooner than 36 months had a very, very strong predictor factor for cancer-specific mortality. So they identified that early biochemical recurrence as a stronger factor, which is intuitive too, but they were able to show that. So a couple studies just to now show the comparison between radiation and the surgery. And I need to be careful here so Dr. Felix don't get too mad at me. But there's no randomized studies control head-to-head comparison. The only trial that tried to do that, a Scandinavian trial, was aiming to accrue 700 patients. They actually closed early with 90, so didn't have power to look into this. So we're going to look at the systematic review of meta-analysis, and this one, for example, look at 17 studies. 16 of those were retrospective series, over 13,000 patients, and as you can see in this forest plot, looking at the overall survival, there was a trend towards surgery being better for patients with a high-risk disease. If you look at outcomes for cancer-specific survival, similar results, and also for non-prostate cancer-specific mortality, same thing. This is actually one of the most controversial data. Dr. Zalewski is the chief of radiation oncology at Memorial Sloan Kettering. He's the first author on this paper, and they published in 2010 another comparison using Baylor and Memorial Sloan Kettering surgical series versus the Memorial radiation therapy series. And you can see they used IMRT with a high dose greater than 81 gray on these patients. And the large series, 2,300 men, about half of them were assigned to each group. With a 15 years of follow-up, you can see the gold curve here is radiation with a little bit of a lower survival, and this is the predictive mortality. So they inverted the radiation therapy is the blue curve. So you'll see the blue curve having a higher predictive mortality in this setting. This is just a table to show the number of events, especially in the high-risk group. If you look at this number versus this number, radiation versus surgery, and at 8 years follow-up, radiation versus surgery, more events noted in their series. This is another systematic review, a very large number of patients, similar outcomes, box plots favoring surgery versus radiation for overall survival, and a similar thing for cancer-specific survival. So it's important for us to just highlight the limitations when you look at this data and this comparison, because the radiation therapy studies, they lack large prospective control randomized trials comparing to surgery. The database and the retrospective observational cohorts, they have inherited bias. The radiation therapies, because they use long span on their series, include patients from old therapies together with new therapies. So there's changes in techniques, there's changes in the equipment that might account for the differences. There's dose delivery that is not standardized in all those patients that may be affected by the template that might have been changed, updated, the fractionation, total dose. There's also different combinations, external plus minus brachy, plus minus hormones, and also duration of hormones. If that's not standardized across the board, you're going to see differences in the results. There's selection bias as well, so we know that very likely patients who were assigned for radiation and hormones probably have worse disease to begin with. So to be fair, we need to take into consideration all these limitations before we say one modality is better than the other. And additionally, these recurrences after radiation could be just de novo tumors coming back in a prostate that is retained versus a recurrent or persistent disease. So in conclusion, high-risk prostate cancer is a heterogeneous group of tumors. There's definitely a role for local therapy in this disease state. The multimodality approach is the most important consideration when we're managing these patients. And I think if you need to go home with one message from this talk, is that high-risk prostate cancer equals multidisciplinary approach. So these patients need to be informed, need to be counseled that they might need, it doesn't matter if you start a radiation surgery, they will likely need several different modalities to control their disease appropriately. Radical prostatectomy with a no dissection is an excellent approach, part of as part of this approach, potentially as the first-line therapy, and extended node dissection, it's mandatory, especially in high-risk disease, so that's not open for discussion, and further studies are needed, so we can discover more genomic biomarkers that can better predict the biological behavior on these tumors, and we can select best candidates to individualize therapy and assign more aggressive therapies for more aggressive tumors. Muchas gracias por su atención. Estaré contento de responder sus preguntas. Gracias.